How's everybody doing? It's a small room. It's okay. I'll talk. Well, I appreciate everybody coming, and we have a great panel here today with very esteemed colleagues. We're at the intersection of AI and labor, which many people are talking about in the news. Many people are talking in many settings. I just wanted to start with some stats before we kind of go down the line and do quick intros. I'm going to assume everybody read the bios. So we're not going to do bios, but we're going to kind of go down the line and people can introduce themselves and ask a quick comment. But on the labor front, I don't know how many people follow all the healthcare labor. I'm kind of a labor geek. I spent a lot of time thinking about it. I've been thinking about it for decades because if you're in the technology space, at some point in time, all the investment that we have made in technology has to change what is a very hands-on labor market in healthcare. So there's 23.5 million people in private sector healthcare services and social assistance jobs in this country. It's the single largest labor pool in this country and continues to be, regardless of what we're investing in technology, which I'll get to in a second. If you just look at the labor report that just came out, I'm going to read this so I don't get it wrong. You know, we basically are averaging 74,000 private sector jobs a month, which is down from 130,000 jobs a month last year. And outside of healthcare services, the sector that I just talked about, the private sector only added 9,400 jobs a month on average this past year. So 85% of even the reduced number of jobs that are being added per month are coming from the health sector. Right? And so if anybody's a real geek and you go back to 08 and the 08 downturn and you look at those labor trends as well, you'll see the only reason that the labor markets floated up during 08, during that very downturn, was because of healthcare. The only time in my lifetime of working in healthcare in 25 plus years where labor trends were substantially down were through COVID because it had to happen. And a lot of people left the sector actually during that time as well. So it's a really fascinating thing. Now, flip that around and think about tech. And think about the amount of money we've invested in technology. And again, for people that have been in it for a long time, most of the people on the stage have been through it. We put $38 billion into a government program called Meaningful Use. $38 billion. We put 10 to 15 billion on average of venture capital dollars into technology per year. Right? And if you think about that, right now, getting to AI, the AI race is on, as we all know. AI has been in healthcare for a long time, mostly predictive, but when we think about generative, we'll mostly be talking today about generative and agentic, is my guess. But when you think about that, over 60% of all VC dollars today, this year, last year, are going to AI-centric companies. Over 55% of all the value of all those private companies right now have some tether to AI. So the gold rush is on, the money's on. I don't know if people watched CNBC this morning, but you saw Trump and the UK Prime Minister talking about all the money they're investing in the UK. So it's everywhere. And so the idea of this panel, I think, when Katie and the team put together for MedCity, is really about the intersection of those two things I just talked about statistically, AI and labor. I'm still waiting for ROI. I don't know, many of you are very healthcare providers in the room, but like I'm still waiting. I represent a firm that only works with healthcare systems and payers, and I'm waiting for ROI, demonstrable ROI. So we'll probably talk about that a lot in this cycle. But just as a backdrop, maybe we'll go kind of down the line, starting with you, Steve, and just kind of give a quick intro on yourself. Let's not do bios, and just talk a little bit about how top of mind right now at the intersection of AI and labor. What's front and center for you?
No, happy to. Thanks for having us. By the way, I told Neil in the previous panel they should aim for like a B plus, so don't stand the bar so high. Well, I think they knocked it out of the park. So us and the rest of the panels, we have a lot to stand up to. Yeah. So thanks, Neil, for that. Steve Miff, CEO of PCCI. At the core of it, we're AI cognitive computing innovation hub affiliated with Parkland. We work at this intersection between clinical information and social determinants of health, and build solutions to help those that serve vulnerable populations. Experience, we have over 10 fully deployed AI models, so sort of have a lot of experience through that process, a lot of cut and bruises, but also lessons learned. I think, to your question, Keith, sort of what's top of mind is, as it comes to the intersection between AI technology and the workforce, are actually two key things. One is the adoption of the solutions that we build. Because if they're not fully adopted, it could be an amazing solution. It's just cool math. And when it comes to that, there are two things that stood out to us. One is the need for trust. And that's hard to achieve. And I think you need sort of three things. One, and this is important both for health systems that are thinking about adopting and for those that are developing technologies for these health systems or payers. One, there's increased focus on developing rubrics to evaluate at the front end the technologies from multidimensional all the way from obviously the metrics, but how it's being deployed. And that's a moving target because OIG, NIST, et cetera, state regulations constantly change. So that's key from a trust perspective. I think, too, it cannot be a black box. So anything that you can do to provide insights and additional real-time information behind those outputs and algorithms is critical. We developed a technology called iLet that really helps bring real-time insights to the frontline staff behind any predictive model. And the third is the ability to automate the monitoring of the models that you deploy. Because once you open up the gate, you're going to end up with dozens of different AI models. And the question about asking, how am I going to keep up with monitoring this consistently as an organization? So we've been focusing on developing algorithms and methods to actually be able to monitor the performance of these models real time, because again, it becomes overwhelming to keep up with them. And that actually builds trust with the team they're using, knowing that somebody or group is continuously looking at those and alerting if something goes off track. The second part I touched briefly on is the adoption of the frontline staff is still afraid that they're going to lose their jobs. So there's a resistance as you're introducing these solutions on what is it going to mean to my team. So I think that's real.
Great. Jess?
Hi, everybody. My name is Jess Botros. I am here representing Ardent Health. We are a hospital system, 30 hospitals across 6 states. So we have a lot of geographic diversity as well as patient diversity in our community. I'm focused in my role on all things project management, our strategic portfolio, and a lot of the big rocks in that strategic portfolio tend to be those like really big transformation type efforts. And when we think about that today for us as a provider system, right, like we really want to make sure that our clinicians can spend as much time possible with our patients and have the best tools in hand to do the right work at the right time with our patients. So we're really excited about the potential, but with the potential comes a lot of responsibility on the back end and a lot of cleanup, right? To be frank, right, in order to do this in the right way, you have to have your house in order from a data perspective, from a trust perspective. You think about change management impacts and making sure that people are really along for the ride and really understand why we're doing what we're trying to do. It becomes super important. So that's some of our focus.
Thanks. I'm Abhinav Shashank, co-founder and CEO of Innovator. We build the information infrastructure required for AI to work. A lot of what we've basically been focused on in this entire AI gold rush to a certain extent has been around 2 broad thematics. I think everyone initially will rush towards a bunch of like point solutions in general. Like when the $38 billion basically got like released, what ended up sort of really happening was that everyone went and said that I am going to go build an EHR or I will have an EHR. And 15, 20 years later, we are still solving EHR interoperability. And what is basically going to happen, like I think, like again, as we are sort of really rushing through this entire thing, is that agentic interoperability is going to become like a nightmare that we are all going to basically deal with. And I think like that's going to be far worse than what we are realizing today. And so yes, like I think like there is a need to basically do all of the cool things that we are sort of really doing and all the algorithms that we are sort of really building. But the key thematic that we need to basically think about is that what is the information infrastructure that we sort of really set up that allows for information to get exchanged between things. We've gone through one cycle of like developing things without internet in place, and like everyone felt like, okay, like I will have this one monolithic system and it will basically solve like all of the problems. But what ended up sort of really happening is that information exchange got very, very, very hard. Like, and because all of the problems that we face today, like if you really step back and try to abstract it out, all of the problems that we face today is because information exchange is hard. Whether that's basically like I think the claims process being hard, whether that's being coding like I think like being hard, whether that's basically being authorizations being like challenging, whether that's being like value-based care not being successful to the degree that we've sort of really all wanted. It's all an information flow problem. And like suddenly we are all basically rushing to, okay, let me build like I think like more, but like the thing that we have to realize is that if we did not have like an interoperability and internet infrastructure that exists for these things to basically work, we are going to land up in far more trouble than we basically are in today, because we had like maybe like one, maybe two, maybe some of us basically probably 20 EHRs, and then we basically have like our CRM systems, then we had like our ERP systems, then we had like claim systems and like 76 systems in general like a health system basically has today. None of them work together. None of them work together. And like all we are basically pushing for right now, and which is like I feel like I think where we are spending the time is, let's have 76 more. Like and and I don't think that's the answer. Like the answer is basically, can we connect these things? Like, can we get them to work together? Like it would be great like if we only had like one system and like everything worked, but the truth of the matter is that is not going to happen. Like we are going to have like I think like software companies all across the world. There is going to be great software that is going to get built like all across the US, like in general, and what we need to basically work on is to create a system that connects these things and makes them really work together well. If we have that, a lot of the problems that we are talking about, the medical inflation rate, like all of those sort of like things, I have like very contrarian views on everything, including this, but I would just think like if we got these things to work together, we would be in so much of a better place than basically trying to get 20 new things per se. So yeah.
Great. Well, good opener, and a heads up for everybody. We'll give you about 5 minutes at the end for questions, so feel free to fire those up and think about them as we go through. So, so let's spend some time on ROI, and maybe Jess, we can start with you, because you're literally in the middle of all this with Ardent. How do you think about ROI and technology, and specifically some of the things that are going on in AI today? And I don't mean to bring up a competing publication, but I will for a second. Modern Healthcare had a great article this week about vendors having to now basically contract for free and build guarantees into an ROI. Yeah. And so, like, how do you think about that as somebody that procures these software tools, and then how do you balance that with some of the labor stuff that we're talking about and where that's at? Yeah,
I mean, I think it's a really interesting conundrum for the season of AI that we're in right now, right? For me, I think it actually even starts before that. It starts from really understanding what problem are we trying to solve and really staying firm on that as an organization. I think it's really easy for folks in the industry to go chat with folks and they're like, oh, actually, yeah, I have that problem, and now I want to solve that problem. You got to have the problem first yourself and then go out and seek it. So that way then what you actually want to get out of that tool becomes a lot more crystallized and clear. So we try our best to keep that frame of mind when we go out and look for solutions to our problems. And that could be, a net new startup that is doing something really innovative. It could be an existing partner that we already work with that is looking to forge in a new area. It really runs the gamut. And so we really try to keep that piece in mind before we even start. So that way then we're not losing the thread on ROI as we go, right? And not only that, but independent of whatever vendor or software that we're working with, who is on the hook for maintaining that ROI? Not only during implementation, but after, right? You've heard lots of folks on stage already talk about adoption. That is the piece that keeps it all together, right? If you don't have people in the system doing the thing that you're expecting them to do, well, your ROI goes away and now your problem is also not solved, right? Which is what you need to start with. And so from our perspective, we ask lots of great questions. Some of those questions are really hard to answer, not only of the vendor, but sometimes we ask questions that we ourselves may not have the answers to as well. And that takes time. We have to pause and say, all right, what data do we need to help us answer this question and figure out if this is really something that we need to drill down on with the vendor or not? And ultimately that drives our decisions, right? So we've done lots of great pilots of AI-based products this year, and I think you have to have an experimentation mentality. Like, it's okay to fail. We're going to try it, and it's okay if it fails, right? It's okay if we don't get what we expect because we're trying it. It's a pilot. That should be inherent. But just making sure that we can follow that all the way through. We released some news this week on our work with Ambience. We did a pilot with them earlier this year for some scribing capabilities for our providers with 100 docs. Knocked it out of the park. Awesome. We saw really, really great results on that pilot, but it's because we spent the time up front to figure out what are the things that are important to us that we care about to see from a data perspective all the way through. And as a result of that successful pilot, now we're expanding enterprise-wide, and all of our physicians hopefully soon other staff too can really benefit from that technology and get the savings in their week so they can practice to the top of their scope and also to the top of their schedules, right? I mean, it has benefits all the way around. And then not only that, but they're also a lot happier, right? They have a huge change in job satisfaction. They tell us like, hey, don't take this thing away from me, right? Which is great. I think thinking about ROI from a holistic perspective becomes really important, especially in this stage.
And that's a balance of maybe some good ROI, but softer, not
Definitely.
hard ROI, where it's
Definitely.
helping people live a different lifestyle.
For sure.
Abhinav, when you think about, say, some of the recent procurement cycles you've been through with the platform and some of the capabilities you have, are you seeing people like Jess and other buyers being a bit more scrutiny around ROI? Or are you feeling it's a little bit more of the same?
So we've done this like long enough to basically go through like a little bit of these cycles. Like, I think the scrutiny is higher, like for sure, at this point, because the noise is so much, right? Like, and like the EHR will do everything, the point solution will do everything. Like, so there is a lot of noise, frankly, like that people on the other end, which are buyers, like are having to sift through. Like, and what they are trying to suss out is like, do you really believe in what you're saying? Because claims are aplenty at this point, right? Like, everyone is basically going to solve all of the crisis in healthcare, like within the next 2 years. Like, and so given the amount of claims that are effectively out there, there is increasing degree of, okay, like we have to look at, can you basically deliver it? If you can deliver it, I will pay you for the outcome and take the risk on the outcome. And frankly, the way you should think about AI is that it merges not just the software workflow, but also jobs to be done, right? And so for the first time, you could contract for something getting done. Like, so what we've basically done is that from our standpoint is to make the platform, like I think, like incredibly cheap. Like, get the information infrastructure effectively flowing. Don't necessarily pay too much for that. But every time I deliver you, like I think, like an outcome, I will basically take, like I think, like some dollars. So for us, like I think, like our pricing model has basically evolved into outcome as a service to a certain degree. Like, and I don't think it's a bad thing. Like, I think it's a very win-win scenario, because this could finally be the thing that could cause technology to be truly deflationary, right? Because you spend hundreds of millions of dollars investing in technology with the hope that at some point this will do something. Like, and nothing's really changed. Like, frankly, like, healthcare has been the only industry in which, like, we've put technology, everything became expensive.
Yeah.
Like, it's like insane.
It's actually
right?
it's actually broader than that. Healthcare is the only industry where an innovation comes in, the price goes up.
Yeah.
not down.
Right.
It's not just technology, med device, drugs, everything. The price goes up. So it's quite fascinating. And Steve, from your perspective, and I know you contract with a lot of nonprofits, sometimes some state organizations, associations, public health. Like, is the scrutiny in more the nonprofit arena in some of those types of organizations as high as it is, say, in the private side?
I would say it's even higher, and it's been even more challenged recently, with just understanding sort of their financials. But I think there's a tremendous opportunity for AI to make an impact, and I think the encouraging part is that any public health systems probably recognize that, and actually they're actively looking for solutions to help them solve those problems. What Jess said, I think it's really important. It starts with the problem, and a very well articulated problem, and then solutions coming in to figure out how do I help solve that. Otherwise, you can't, as what the developers say, hey, we developed something really cool, let me come tell you what a problem that you have that my solution solves. It doesn't work well that way. They're looking for three key ROI metrics. One is clinical improvement. Two, any type of cost saving or revenue augmentation. And three, any workforce optimization. And I think, Maddie previously in the panel articulated those nicely. If you can hit 2 out of the 3, you're great. If you hit all 3, home run. But those are the things they're looking for. One example that of a solution to make it a little bit real that brings this to life that we built and deployed with Parkland is around a digital imaging surveillance large language model. The problem they were having was that they would do a lot of imaging, 630,000 imaging studies per year, whether it's somebody coming in the ED with a chest contusion, but then the radiologist would find an incidental, finding a node. Then in their notes would like, hey, this patient we should follow up in 3 months or 6 months because this is something that should be kept an eye on. So imagine when you have 630,000+ imaging studies that are being done, it was hard. But what they were finding again, those patients that said something in their notes would show up 12 months later with advanced cancer, and it was too late to do something. So they put together a team of 20 individuals to comb through the radiology reports to find these incidental findings and follow up with them. They had a hard time scaling. It's like, great, we have 20 people, but still, we can literally only identify 3,500 individuals per year. So this is where perfect place where AI, LLM can really make a difference. So collaborate with them to build a model that actually scan through all these notes, find the needle in the haystack, and tee up what's the finding, what type of imaging was recommended, when, and why. And now in like literally, milliseconds, on an annual basis, we identify 23,000 individuals that require follow-up and prioritize who needs it because you still can't get to everybody. The AI solution is 98% accurate. The human, the team of 20, 94%. So you're doing better. You get to more patients with, depending on your business model, additional imaging studies that are generating more revenue. You have a huge workforce optimizations because you can do more with actually less people. You can deploy those folks to actually follow up and get people scheduled, and you're doing it better. So it sort of hits the trifecta, but I think it comes from, I just said, it's a very specific need. Where can a solution do it better and augment or do it differently than is being done today?
God, it's really interesting. And then, Jess, kind of following on that, can you think of an example recently, not Scrab, we'll get away from that one for a second, where you've contracted and then or your organization has contracted something on the AI domain and tech domain where you literally had a budget impact from a cost containment standpoint? Are there any, not to put you on the spot, but like are there any examples you can think of like that, more recently?
Yeah, I'll just kind of touch on, one of the journeys that we're on right now is looking at ERP. So not necessarily clinical care, but right, like the backbone of any business that is in our space here, right? We're on cobbled together systems, right? It's really tough, and as a result of that, we have super disparate workflows. We have, people doing all kinds of different stuff across the enterprise, and part of what we're looking at as we build out that TCO model, right? We're still in selection mode, but really looking through and saying like, all right, how does this actually drive our workforce optimization and making sure that people can do the right work? And to an earlier point, right? It's not about replacing folks. That's not what we're trying to do, but allowing them to do kind of higher level work while, this glorious AI can kind of do some more of the other stuff. So that's, I think, one that's really top of mind for us right now as an enterprise. We're also looking at a lot of virtual care. So how can we utilize tools on the market to bolster virtual nursing, virtual attending, which would drive additional patient volume into our facilities, and keeping patients closer to us within our markets. So lots of interesting action happening right now, but taking that all the way through into the financials, requires a lot of kind of everyone involved.
Got it. That makes sense. So we spent a lot of time a while ago, a number of years ago, when the Gen AI was coming more on the scene, thinking about this idea of crawl, walk, run over a decade.
Yep.
And just kind of replaying what you're saying, then Abhinav, I'd love your opinion on this. Like, are we kind of in, like I always said, we're kind of in this crawl, kind of moving to walk a little bit phase right now. But is that really about productivity lift? Not necessarily full-scale labor arbitrage lift yet.
Yeah, I mean, I think we're pretty far from that, right? You hear a lot of talk about agents. It's like, okay, agents are going to be in your org chart. You're going to have people, you're going to have agents, you're going to see their productivity, and then now suddenly if you see the agent's productivity, you're going to have to see your people's productivity. And that's a whole different situation.
Right.
I think we're pretty far from that. I think right now we're crawling, we're getting distracted by like the, music and the shiny toys that are on the floor that we're, kind of crawling around. But yeah, I mean, I think it's early stages, right? We have to grab onto the things that we can grab onto and can tell a story around and can get value from. And some of those things are, hard dollars, hard value, and some of those things are a little bit more subjective and softer. So.
And what do you think about that, Abhinav?
Again, I have a very contrarian view on this as well. Sorry. My general thing is like when you start looking at like I think like AI from productivity lens perspective, you are effectively saying that like the current model effectively works and I just need to do this better. I don't think like that's the case. Like we're basically adding 3.6 million people, like I think like in Medicare every year. Like and something needs to give. We're actually like I think like not spending the money wisely. Like we spend $1.5 trillion like every year on administrative waste, and that money should actually be going into medical care. And so, if you asked me that as a percentage of GDP, will healthcare basically become like lower or higher? I think like the answer is probably higher, because like I think we just have like more people to take care of, like more people are living longer, and that hopefully that continues to basically be the case. And if that's basically going to be the case, people are going to need more care. And the way the system is basically like I think like set up today, we are going to crumble. Like there is not enough staff, there is not enough people that can really like I think solve for these problems. And if we don't really start reimagining like how we are going to deliver care and what does this basically mean, it's not fun like for anyone, right? Like I think like COVID basically showed us a little bit of what worst case scenario could look like. And the thing is, we are incrementally getting there. Like the pressure on people for doctors is basically very real. They are still basically spending a bunch of time in just administrative work. I think there is an opportunity to rethink a lot of what we are doing today. Like, and if we only look at it from a productivity lens, I think like there's going to be advancements in productivity. We've seen this like in our customers, we've seen this internally. All of those things are true. But the real opportunity, like I think with AI, is that can I reshape like one thing?
Yeah.
Like one function, can I basically look at this function and what would it look like if all of this new technology was basically present? Like we're talking about like story and like a lot of what we are trying to do is what does basically cardiology care like look like? How do you basically like think about that like few years in the future? Does AI play a role? We've been talking to Medicare about the fact that why do you pay us for 20 minutes of time? Like because an AI can basically do a lot of work that I can send you documentation for. Why is that not a code? So the payment model needs to evolve. Everything needs to basically be like, I think, like thought through on if we had this technology layer available, can I do things differently? And based on that, can I incentivize things differently? My view, like if I was a health system administrator, I would ask every vendor to basically be outcome oriented.
Totally.
Tell me basically like what is the outcome that you are going to guarantee me, and if you can't, like I think like that there is the door. Like right. So I think like more and more putting accountability on vendors as well, that we are all going to be in this together.
Yeah.
Like we are either we are going to move a metric like this way or that way, or we're not.
Yeah.
Right.
I think it's a great way to transition to Q&A because I wholeheartedly agree with that. Where I think you're going to see a different scale of sort of responsibility on the vendor side engaging. Any questions? We've got about 4 minutes or so.
Yeah.
In relation to the changes that you may be talking about, what about real-time medication use data? That has never been part of the arsenal for medical care, for health care. Can it be done? And can it be like a financial, or should I say a money model? You take your money to the bank and they account for it, but you know what you have and you know what's there, but it's authentic. That information, if authentic and constant, then that will give healthcare something that they can work with, that they know they don't have yet. There are tools that are being developed that can do this. How do you feel about those possibilities?
Like I have a view, but like I think like you guys would probably have like a more health system view like on this. My view is that a lot of these things like integration of devices or like pharmacy at the point of like all of these things are like much more in the realm of possible today. But again, like the challenge on all of this is again what we started with and what I said like I think at the start, information flow is not necessarily there. Like so how do you bring all of these things to create a care pathway that can be reimbursed is a reimagining of like the billing code or like the reimagining of like how we basically get paid. Can it be done? Yes. I think the technology is definitely not a barrier for this. Like the technology for each one of these things, tracking pills, like I am not wearing my Whoop device today, but like your Whoop device, like a bunch of these things basically exist today. And does this lead to like better health for the patient at the end of the day? Yes. But most of us are not really thinking about like solving that problem in meaningful enough like ways, because the reimbursement model actually does not incentivize it, right? So a lot of these things will need to sort of really evolve like in parallel. There is a technological shift that will need to happen. There is a payment model shift that will need to happen. And then there will basically like, if all of that happens, then the biggest barrier is going to be the cultural shift that needs to happen. Like, so those are like, I think the three barriers that exist in terms of where the technology exists to where it will basically get to mass adoption. I think like we are probably 5 years away.
Let me maybe give you an example where kind of that's maybe coming at a small scale alive today. I think the point they're making is really important, and unfortunately the patients that Parkinson's serve, they do not have wearable devices that you can collect information with. So you need to figure out how do you actually get their information from the available data systems. It's not enough to just use the EHR data or use your claims data. I think you need to supplement and augment that with data about the environment where people live. Need to figure out how do you do that at scale. We developed a method out of need, more necessity, that models individual block groups and the characteristic of block, and we're tagging them to every single patient record real time to augment what we have in the EHR to really understand the environment. you need to also add medication data and use the systems that you have. Here locally, SureScripts is data that they have, the health system used, bring that in and incorporate in their models. We built a model for workplace safety because of the need to help predict a violent event from a patient towards a staff. It is an incredible problem in healthcare, particularly as it's gotten even worse since COVID. That model requires all those three characteristics in order for it to perform at a level that is acceptable by the frontline staff. It has the workforce optimization because, and you also need to think very carefully about how you deploy it based on, Rahid mentioned yesterday, like what is mental behavioral health. In this case, you're predicting a behavior, which is sort of the line. So how do you actually stage that deployment? In this case, the organization was using the Brosset tool to be able to screen, the likelihood of patients. They're doing it all patients. Imagine how much workforce it takes to screen every patient. So we use this AI model that incorporates these factors to predict levels of risk for a patient, and then just screen those that are at high risk and likely. It reduced the number of screens to 30%. And that's you administer the Brosset tool to just those 30%. It captures 9 out of 10 incidents, so you're missing one. So it's also, you need to be able to work with the clinical side. What's an acceptable risk, and what's the balance between the workforce and the efforts that it take versus you're comfortable that, you're not going to have 100% compliance. That's why I think it's an example where this still, can happen today. Is there, a longer path? Absolutely.
Well, I want to thank everybody. I know we're up in time, but thank the panelists, and people will probably be around for a few minutes if they want to catch up for a couple questions afterwards. But thank you.
Thank you.